The following podcast is part of a certified educational activity titled The Challenges of Choice in First-Line EGFR Mutated Non-Small Cell Lung Cancer. Practical Guidance on Optimizing Approaches. Access the entire activity and complete the post-test at peerview.com/YJT860. Downloadable slides and practice aids are also available.
Dear colleagues, it's my great pleasure to welcome you to this curriculum activity, which is titled The Challenges of Choice in First-Line EGFR Mutated Non-Small Cell Lung Cancer, Practical Guidance on Optimizing Treatment Approaches. My name is Solange Peters, and I'm the director of the Oncology Department in Lausanne in Switzerland. But most importantly, I have with me my colleague and friend David Clanchard, who is one of the leaders of this intensification initiatives in EGFR mutations, who is working at Gustave Roussy in Villejuif in Paris, France. The idea of today is to try to cover together the evidence supporting different EGFR-targeted therapies and rational combinations in this patient with a newly diagnosed advanced EGFR-mutated non-small cell lung cancer. We try to understand which factors should guide individualized selections of first-line therapy for diverse patient population with advanced EGFR-mutated non-small cell lung cancer, and potentially how to effectively improve and collaborate better with other MDT colleagues to achieve the optimal patient monitoring, the management of adverse events, as well as, of course, favorizing the best possible treatment outcome at the end of the process. So let's start from the beginning. I will create a little bit of the background, and David will deep dive into the new data. Where are we now, and what were we doing until now in EGFR mutated non-small cell lung cancer? So the story is a kind of a long story now from 2009, where we have been seeing the first data about EGFR TKI of first generation, with, as you can see, regulatory acceptance variable over time, depending on the continents, from China, US, Europe, but showing and showcases the evolution from first generation to a short existing second generation TKI to end up with third generation EGFR TKI, better affinity for the EGFR, but also better specificity for the mutated form of EGFR, meaning better tolerability, to the last point of that slide, which is intensification, meaning combination with what we will discuss, the amivantamab lazertinib combination, or osimertinib in combination with platinum doublet. The reason, this is the new, by the way, ESMO guidelines, very important, because we have been courting these opportunities now, and we have been giving, remember, you always have the level of evidence, which is one, because they are well-conducted randomized trial, but also the degree of recommendation, which means what is, as experts, our favorite move. And now you can see that we have a favor, an A versus a B, to give combination as compared to monotherapy. So we have ranked a little bit the idea of intensification in our guidelines. So why did you do that, and what is the evidence supporting the clinical options? So first of all, keep in mind that we have two actionable, I would say, classical mutation, deletion in exon 19 representing more or less 50, sometimes 60%, and exon 21 point mutations, the L858R, 40% of the mutations, and some exon 20 insertion. We won't discuss them today because they are less sensitive to what we discussed today, and rare, even rarer mutations which have their own sensitivity, but we will focus on exon 19 and exon 21 today. Roughly, if you think about stages of the disease, they are present across stages to the same percentage of patients depending where you live. But in our countries, David and myself, it's probably 15 to 20% of our patients with EGFR mutation. It's very important to keep in mind that this has to be tested in stage 1, 2, 3, and 4 at baseline if possible, accompanied with other actionable mutation and with a PD-L1 expression. The best is to do reflex, an NGS plus PD-L1, but it's not available everywhere. Let me move to maybe the testing hypothesis. Would we like to make sure that EGFR, because it's the topic of today, is tested everywhere? We can still not confirm this is the case. It is the ISLC survey from last year showing an improvement from 2018 to 2024, where now 67% of our colleagues estimate that more than half of their patients are tested. So it's still not a lot. Half estimate that half, so it means that there are lots of non-covered mutations, and mainly in late stage. We know today that also early stage, because of adjuvant setting, should be tested, but mainly in late stage. If you ask about limitation, this is reimbursement, so cost, time, sample quality, access to sample, and access to testing and awareness. So here in these papers, I invite you to go through. The ISLC is proposing solution for time after time, improving the 67% to 100% of the 100% of patients, so trying to bridge the gap. We come from there. That was the first third-generation randomized trial. Osimertinib was compared to erlotinib or gefitinib, the first generation, showing here a benefit in overall survival. 32 months going to 39 months, statistically significant, clinically meaningful, with, of course, less toxicity with osimertinib because of this, I would say, customized affinity for mutated proteins. So this was showing why osimertinib is better than first generation. From that, we decided to discuss this intensification with FLAURA2, not only osimertinib, but let's give to first-line treated patients osimertinib plus platinum doublet. This is the FLAURA2 design with the first reading of a very important improvement of PFS. Osi plus chemo versus osimertinib monotherapy give rise to a hazard ratio of 0.62 from the very early step of this curve. This has been shown this year to translate into a significant overall survival benefit with a hazard ratio of 0.77, and at 4 years, with lots of censoring, an improvement of 8%. At 3 years, which is more stable, an improvement of 12% of survival, which is very significant for our patients. David will show it to you. But this hazard ratio, of course, all subgroups are not powered for significance by definition. But each subgroup you can observe type of EGFR mutation, presence of ctDNA at baseline, presence of p53 mutation, bone metastasis, liver metastasis, CNS metastasis. All of this subgroup benefit to the same extent in terms of hazard ratio to the intensification strategy. And you will see later on the Kaplan-Meier. It is quite important for you to keep in mind that being underpowered, there's no discrepancy in any of this subgroup in terms of benefit observed, speaking for a prognostic impact more than anything. Mariposa is, of course, the elephant in the room. This is the other intensification opportunity where osimertinib as control arm has an exploratory comparator of amivantamab lazertinib. And here you will see with PFS the same improvement in hazard ratio of hazard ratio 0.7. So quite interesting curve showing the same thing. And we have been exposed to an interim analysis of survival where the median was not reached and cannot be invented. So the hazard ratio was 0.77, which was still not significant, but we need to wait for more mature data. And remember, this curve have some initial crossing, so nobody should guess because the hazard ratio is not absolutely proportional. Toxicity, we'll cover them later on, but toxicities are very different. This is the Mariposa overall survival curve I described before. Look at the crossing of the curves. So basically, hazard ratio 0.75 with more mature, and now it reached significant at this analysis, but still the absolute benefit at 3 and 4 years cannot be quoted today because of this slightly non-proportional hazard ratio. So we need to wait to really know exactly the magnitude of difference between amivantamab lazertinib and osimertinib at milestone time points. So that's where we are with this data. And when we think about a patient, David, there is this, of course, FLAURA osimertinib monotherapy, which is still an option. It's called AB in our degree of recommendation, not A, but AB. But we have this two intensification. And this patient, 63-year-old, as usual, never smoker, is diagnosed with an exon 21 mutated non-small cell lung cancer, PD-L1 negative, TTF1 positive, of course, with a PET-CT showing a 3 centimeter left lung nodule, but several bone mets, 4 subcentimeter parenchymal lesion in the brain without edema. So basically something which unfortunately shows a metastatic disease, but I would say no threatening lesions, still quite a lot of lesions. So the main question is, how to look at what I presented before, thinking about these patients and how to make the decision. And maybe I just jump to you. This patient is a bit intermediate way, no threatening lesions, but still brain mets and bone mets. So would you consider monotherapy or osimertinib for this patient, David?
I would say nowadays, Solange, what you have presented already, so that means nowadays for this type of population, and particularly because you have different factor of poor prognostic, I would say you have the brain mets, you have the exon 21 mutation, you have the fact it's a high tumor burden with multiple mets, extrathoracic mets. So this population have a poor prognostic, despite they will respond nicely to osimertinib. The issue is the duration of response, the magnitude of benefit of PFS, and nowadays of overall survival. So that means nowadays, when we have shown that the intensification clearly and significantly improve PFS and overall survival, I think this is typically the patient for which I will have no discussion. I will go for intensification combination. That means osimertinib and chemotherapy would be my third choice. You can have the choice of amivantamab and lazertinib with different safety issue. And particularly, and this is something we might discuss, particularly for the brain mets, I'm really confident what have been shown in the FLORA2 trial, particularly the intracranial brain response, which is nearly 15% complete intracranial brain response with the combination, and clearly with an important benefit in terms of PFS for this type of profile with brain mets. And when you have the overall survival, when you have a median overall survival that reach 4 years nowadays, it's unprecedented. So for sure, you have a lot of factors for which we must discuss and propose typically combination, and osimertinib chemo would be the third choice with no discussion from my side.
I must admit that I don't know if it's the same for you, seeing the survival of FLAURA2 and seeing the data developing over time, that for me, the paradigm has changed, because I tend to initially consider that I would propose an intensified regimen. And as you did, I prefer FLAURA2, so chemo OSI to all patients. And the ones to whom I discuss monotherapy are the exceptions. So the exceptions of patients with maybe an excellent prognosis, but not even sure. But we all have these patients who refuse chemotherapy, who have contraindication to chemotherapy because of age, fragility, or renal insufficiency. So I would probably take the other way around, really thinking about, let's go for chemo osimertinib and consider who are these patients who might not be suitable for that, or maybe be refractory in terms of not willing to receive this kind of regimen. Because I think, to me, it would be the first time in lung cancers that we discard from our brain a 10 months benefit in survival. I mean, 10 months is better than most of the things we do across the disciplines of lung cancer. So I think it's quite fair, at least, to have this discussion with the patient. Do you agree?
I'm totally agree. So that means for me, the standard of care nowadays, you improve the OS significantly, and 10 months improvement in terms of median overall survival. I think there is no discussion nowadays. This is what we want to reach for our patient. So that means nowadays intensification should be considered aussi chemotherapy at the standard of care first line, AMI, lazertinib. And totally agree. So that means after which patient for which I can still go for monotherapy. And I think probably some elderly patient, frail patient, patient with no brain mets, probably patient with a low tumor burden, particularly if you have only some pulmonary nodes, asymptomatic, deletion 19, no brain mets again, and this is probably some candidate for which you might discuss osimertinib. But otherwise, I think combination nowadays is the standard, and particularly because finally, I would say the sequence matter. The sequence matter because in the FLORA2 trial, in the control arm, you have 70% of patients that receive, when they progress, platinum-based chemotherapy. So also platinum-based chemotherapy, standard of care until now. And nowadays, you significantly do better to combine upfront chemotherapy plus osimertinib. So that means the sequence matter. Do not wait to apply for platinum-based chemotherapy in second line. You will do better if you start upfront with the chemotherapy and osimertinib. So that's why this is a strong message, because even the control arm, it was standard of care in the sequence of treatment in the FLORA2 trial. 70% receive platinum-based chemotherapy post-osimertinib. So I think there is no discussion for me. This is the standard of care nowadays for the first line.
Yes, I fully agree. Maybe you guide us through the day, and of course we'll discuss Mariposa also in terms of choice later on with the toxicity pattern. Maybe you can guide us through the subgroup, David, to have a better picture of it.
I think this is important to look at this subgroup because finally you have this population. So just show you the different subgroup population. So this is a subgroup population, and this is something important we have looked in the FLORA2 trial. Again, keep it by cautious. It's not designed to compare statically all the subgroup populations, so it gives you the tendency. So whatever the subgroup with the worst prognostic, generally we are looking for, particularly the brain mets, type of EGFR mutation. We looked at the ctDNA, liver mets, bone mets, and mutation TP53 generally with the worst prognostic in this population. Whatever, all subgroups are clearly in favor of the combination of osimertinib and platinum-based chemotherapy, as you can see. The first things, and probably the most important, are patients with the brain mets. Whatever, brain mets, no brain mets, if you look the median overall survival and particularly the rate of survival at 3 years, it's clearly in favor of the combination OC plus chemotherapy. But the most important, and particularly just look the magnitude of benefit in patients with brain mets, clearly you have a higher benefit in these populations with brain mets, and particularly at 3 years. You can see 57% rate at 3 years survival versus 40% in the monotherapy arm with osimertinib. So that's why population of big interest. Type of EGFR mutation, deletion 19, exon 21. Exon 21, generally, whatever, they have a worse prognostic, particularly when they receive monotherapy with TKI. And so we are just focusing here again on overall survival and just look at 3 years, the rate 54% versus 42% with osimertinib monotherapy. So clearly, exon 21 mutation have a huge benefit to receive the combination, but even deletion 19, you still do better with the combination. So that means no selection, but keep it by cautious. Exon 21, I will go for sure with the combination. ctDNA, this is something we looked at. And we have looked also the data on the PFS, and this is something that appeared to be predictive of the benefit, particularly patient ctDNA positive. So you might imagine patients with high tumor burden volume, multiple mets, ctDNA positive. In this case, there is no doubts. Just look at the rate of overall survival at 3 years, clearly in favor of OC plus platinum-based chemotherapy versus OC. But even in the ctDNA negative, even if the magnitude of benefit is less, but that's clearly going ctDNA positive, high tumor burden volume, highly symptomatic patient, you need intensification to significantly improve the benefit in terms of overall survival. And finally, TP53, this is something we shown PFS and overall survival. I would say in both group, whatever, mutated or non-mutated, you have a benefit to make the combination. The things, it's not predictive, it's a prognostic, whatever. If patients are mutated, TP3 mutated, they have a worse prognostic, whatever the treatment, but they derive a benefit to receive chemotherapy plus osimertinib. So it's a prognostic, it's not predictive. Do not make the selection according to the TP3. Both populations might receive the best treatment, and I would say, again, in terms of overall survival, chemotherapy plus osimertinib. The things, if you compare particularly with Mariposa, it's to look at the magnitude of benefit in terms of the brain mets. And for the brain mets, I still have some doubts on the magnitude of benefit with amivantamab and lazertinib. If we look the intracranial PFS, you can see over the time, and I would say over 2 years, finally, you have the same magnitude of benefit before to see finally an advantage of amivantamab and lazertinib. If you compare indirectly what have been shown in the FLORA2 trial, you have an early separation of the curve, clearly in favor of combination of osimertinib plus chemotherapy. They looked also on the TP3 in the trial, in the Mariposa trial. What we can say again, it's a prognostic, it's not predictive. Worst prognostic if you have the mutation, but whatever, benefit to receive AMI plus lazertinib. In term, this is only the data on the progression-free survival. Previously, I showed you the data on OS in the FLORA2 trial. So this is something quite important. Finally, whatever the subgroup, they might have a benefit. So TP3, whatever the combination, prognostic, not predictive, I will not choose according to this type of commutation with the EGFR mutation. ctDNA on the Mariposa trial, it was also looked, this is data on the PFS. You can see the ctDNA at baseline and the clearance at week 9. What we can say, again, it's a prognostic, it's not predictive. Whatever, ctDNA negative or ctDNA positive, benefit to receive AMI plus lazertinib versus osimertinib. And same for the clearance, better prognostic if you have a clearance at week 9 in comparison to patients that do not clear the ctDNA, which is slightly different from the FLORA2 trial, because in FLORA2 trial for the PFS, ctDNA at baseline was potentially predictive of the benefit and prognostic. In the Mariposa trial, it was only prognostic and not predictive, finally, to make the decision to expose patients to amivantamab plus lazertinib. BrainMed for the PFS, same as previously discussed, AMI plus lazertinib seems to do better to have the combination, whatever, patient with brain mets or no brain mets on the PFS. But again, it's not the specific intracranial PFS here, it's a general PFS. So keep it by cautious. And for sure, for the benefit of the intracranial response, I think there is probably an advantage for osimertinib and platinum-based chemotherapy according to the FLAURA2 trial. So that's why probably we can discuss, Solange, about the different subpopulations, about patient high tumor burden, patient with brain met, type of EGFR mutation, TP3, ctDNA. I don't know what would be probably your choice and the point for which that make you decide to go to the combination or probably just to stay with osimertinib, for example, monotherapy.
So as we said before, I think for me it has come to invert the thought and the reasoning, right? Saying that if I can, I would propose a combination first because of this gain of survival seen in both trials. I've been adopting, I find it easier to give, my nurses find it easier to give the FLAURA2. And the toxic pattern that you will describe later on is also an argument for me because of the, I would say, potential detriment of having some visible side effects, being the skin, being the nails, and so on. So I prefer FLAURA2. And of course, my tone as an oncologist, because you always have an informed decision and a shared decision. When you have this patient with several brain mets or threatening disease, close to the heart, pericardial effusion, close to the bone, close to the spine. So sometimes you insist telling you need to receive the combination because really the risk is that at the next progression, it can be extremely detrimental, getting a handicap or something which might even be a deadly event. So we have this patient in which it's not even a question because we know that they will not do very well enough under monotherapy. And this is very often represented by exon 21 mutated non-small cell lung cancer with a high burden, and particularly the extent of the disease or the localization of the disease. So I would say all receive doublet, but I would insist in these patients who really have a threatening disease in terms of burden and location. Of course, older patients, I don't know if you have the same experience, but the 86 years old men, when you discuss the fact that evidence shows that chemoosimertinib is better than osimertinib alone, when you are 86 years old and chemotherapy can be a very bad choice sometimes. I can fully understand that my tone will be different and it might be more kind of an open discussion and the age and comorbidity, how frail is the patient, might speak the other way around. Do you feel the same?
Totally, but probably this is a way we have to discuss and anticipate to the patient. So that means it's always challenging if you see a patient that you will say, okay, you will never receive chemotherapy because you're never a smoker and it will be something just a monotherapy. And finally you say, okay, finally we have to do chemotherapy because it's an EGFR mutation. It's always more challenging in this case. So that's why nowadays I try to anticipate and to say, okay, I don't know what will be the treatment. Probably you still might receive chemotherapy with a TKI, particularly in some type of mutation. And I think this is something, and generally the patient know even before the diagnostic that potentially, even if he's never smoker and high probability to have a actionable genomic alteration, he might still receive chemotherapy. And just to tell, it's not chemotherapy for life, but it could be a short exposure to chemotherapy because finally you will stop quickly the platinum-based chemotherapy and just continue the TKI. But the induction is really important to try to avoid the early resistance, to try to avoid the development of any mechanism of escape and so on. I think the patient nowadays, they might understand. And this is what we do in patients with no actionable genomic alteration. We don't ask any question, even in the PS2, even in the elderly patient. Standard of care is platinum-based chemotherapy and plus IO nowadays. And so that's why finally, if we anticipate and particularly adapt the platinum-based chemotherapy nowadays with only 4 cycles of carboplatin PEM, even sometime in the elderly patient, but good fit because it's a never smoker. And sometimes they tell you, okay, I want to live the longer as possible and so on. And so even the elderly, sometimes you have to push and explain, and they might completely understand why you are starting this more intensification with more side effects, but for a short course. And after finally, it's gone with OC monotherapy, which is sometimes, most of the time, really fine in terms of tolerability.
Yeah. I think you stress something important is the toxicity pattern. What does it mean to give chemo or to give amivantamab in parallel to a third generation TKI? And what I always tend to remind to my young doctors here who tends to consider that there's no maintenance pemetrexed, for example, but it was in the scheme. So you will maybe show the toxicity and also what does it mean in terms of duration of chemo in the trial, right? Leading to this 10 months benefit, how much pemetrexed, how much chemo. So maybe can you guide us through this toxicity and patterns?
So just look, and I think this is an important data from the FLORA2. So that means we look at the duration of exposure to the different compound. And finally, patients receive only 4 cycles of platinum-based chemotherapy. So you can see the median duration with platinum, I would say it's only 2.8 months. Median duration of exposure to pemetrexed, 8.3 months. And median duration exposure of osimertinib, 30.5 months. So you can see it's not chemotherapy for the whole life in first line of treatment. It's a short course. And most of this period, patients will have osimertinib monotherapy completely off of platinum-based chemotherapy. And finally, just compare duration exposure osimertinib in the combo 30 months, in the monotherapy arm 21 months. So you can see the benefit that clearly bring the platinum-based chemotherapy. And finally, to try to avoid the resistance and try to push further the duration exposure to osimertinib. So I think this is something quite important to keep in mind. It's really the first 2-3 months for which you will have the toxicity of the platinum-based chemotherapy. And so that's why finally in the FLORA2 trial, we do not observe any unexpected toxicity. This is a classical toxicity. We know how to manage platinum-based chemotherapy, particularly in terms of GI hematological toxicity, and generally does not impact the exposure of osimertinib, which is something quite important. So finally, tolerability of both combinations is really easy, and we all manage the side effect of platinum-based chemotherapy, which is nowadays not an issue. And particularly, we looked at the toxicity over time, and just look, we look within the first 3 months, 3 months to 9 months, and over 9 months. And you can see that over time, you have a significant reduction of the toxicity because finally you will stop the platinum-based chemotherapy, stop cisplatin or carboplatin, you will stop after a certain time pemetrexed, just run for osimertinib monotherapy. So that's why you have this induction, slightly much more toxic, classical toxicity, and after finally you will keep the safety issue for the patient, which is something quite nice. It's not exactly the same, I would say, things with Mariposa, particularly because you have multiple side effects, particularly due to the B-specific antibody. Again, unfortunately, we have all this toxicity, the skin toxicity, that might impair the quality of life, apparently the rash in nearly 60% of patients, MET inhibition, so you have the peripheral edema in around 40%, you have the infusion reaction, generally after the first infusion of amivantamab, you need to split the infusion to hospitalize the patient, and you have the VTE also, so you need to prevent the VTE in around 40% of patients if you do not prevent the VTE with AMI and lazertinib. So you can see you have to think about the side effect, despite it could be an option in first line of treatment. They have also shown the first event, adverse event, according to the AMI lazertinib. It's not the cumulative event, completely different from what we have shown from the FLORA2 trial. Previously, I've shown you the cumulative event. Here, it's only the first event. So the first event, mainly within the first 4 months. But I'm afraid if you are looking the cumulative event, it might increase over time. And this is something that have not been shown, and particularly in terms of skin toxicity. So I'm slightly worried about this. You need to prevent the toxicity. If you prevent the toxicity with some treatment, some cream to prevent the skin toxicity, to prevent the infusion reaction with corticosteroid, to prevent the VTE, clearly you reduce the adverse event grade 2 or grade 3, but it's not null. And you can see despite prevention, you still have around 38% grade 2 or 3 of skin toxicity, 22% in terms of infusion reaction, 11% of VTE. So not so simple. Many treatments to prevent the side effect, and despite this, you still have the grade 2 and the grade 3, and we don't take in cautious here. What about the grade 1? That might also impair the quality of life of the patient. So that's why it's clearly probably the major issue for me of amivantamab and lazertinib. Probably in the near future, it will be much more convenient to have the subcutaneous formulation of amivantamab. It's significantly decreased the infusion reaction for sure, 13% versus 66% with the EV. It does not reduce the other side effect in terms of particularly the skin toxicity. And potentially it was shown in the Paloma 3 trial, it was interesting. It was previously treated patient, potentially a benefit in overall survival with the subcutaneous form of amivantamab, but that needed to be confirmed, particularly in first line with AMI and lazertinib. So we need to take in cautious for sure, in account the magnitude of benefit, the weight, the PFA, the brain mets. I think this is important, and the adverse event particularly. And I think AMI laser, that's why for me, I would not consider this as the standard of care. Unfortunately, I would say due to the side effect, even if it's good combination, but I think it's missing to well identify the best population because you need to manage side effect, which is not easy and probably much more toxic than to manage a platinum-based chemotherapy side effect in our experience here and what we can see on the different result. I don't know what is your feeling, Solange, if you have the choice in first line due to the side effect.
I would think the same. You know, we have been working with second generation EGFR TKIs, even combination with some antibodies against EGFR. So we know what is a spectrum of this skin and nail toxicity, the paronychia, that we can see with this kind of class effect of blocking EGFR wild type. We were so happy to get osimertinib to be able to focus on the blockade of the EGFR mutants. And somehow the amivantamab is stepping back by this blockade of EGFR to this class effect on the EGFR pathway blockade. And it's something which might be, so I use amivantamab sometimes. It can be in this context, it can be in other contexts, later lines or exon 20. But what is quite important is always to really inform the patient that basically, even for people he or she doesn't know very well, life will change. Life will change because there will be a visible rash, there will be visible lesion in the fingers, there will be, I would say, lots of time to dedicate for prevention also, because you have shown very nicely the cocoon trial, for example. But we need to keep in mind that this is pretty demanding, right? To do all the blister and taping and everything you need to do for the fingers, the cream. It needs time. You need time which, in terms of daily life, change your life, right? Change maybe your family life, your couple life, whatever. So it's better, but a bit complex. Last but not least, I guess the Paloma is showing nicely that it's way better using the subcut, but only on the side of the infusion, which is already something because our nurses hate this infusional reaction, but not only the nurses, the patients too. But it's way better on that side. But still, what really this EGFR toxicity, which makes it visible to the world around, is for me better for a later line of treatment than the front line, because it can be for a very long time. It can be for years, right? So that's something I keep in mind. But I know some colleagues are fine with that. I find for some patients, the lady on the slides look pretty good looking, right? And with amivantamab lazertinib, it might not be the case anymore. You have the same feeling?
I'm totally agree. So that means it's always challenging to manage, and particularly because this patient in first line, they need to have a long exposure to the treatment. It's a cumulative toxicity. And so that means it's always an issue. And despite it's an antibody, so despite if you stop the injection, that means the toxicity do not recover within 2, 3, and even 4 weeks. And after, if you need to introduce amivantamab again, you have the risk to develop the infusion reaction. So again, is hospitalization of the patient and so on. So that's why it's really something challenging to manage. Quality of life, even if the young, I would say, patient can support this type of toxicity, but generally, if they are nearly a complete response, it's always challenging for the social life for this patient because clearly it's marked on the face of the toxicity and so on. So we have a lot of issue. In fact, finally, whatever the type of population. And I think it's clearly missing probably because I think it makes sense to block EGFRm MET. But nowadays, we don't have the rationale in first line why to block the MET. So can we identify better this population for which clearly there is a need to use this type of antibody and for which we can explain why this type of toxicity, because we will clearly bring a benefit. And I think this is something we need to have. It was clearly shown in second line in the Chrysalis trial with AMI and lazertinib, if you just focus patients who are MET positive by immunohistochemistry, in one case, MET positive, it's nearly 60% response rate. MET negative, it's only 16% response rate. So I think it will be pushing the fact that we need to develop for this combination, particularly to better identify the patient. Otherwise, when you have nowadays OC plus platinum-based chemotherapy, I think there is for me, there is no discussion about the choice of the treatment, because you have the benefit of OS in both combination, and particularly I'm much more confident also on the brain mets efficiency with the platinum-based chemotherapy and osimertinib.
I agree with you. We still need to define who are these patients who might, by the way, benefit more than once from one strategy or the other one, and MET as a biomarker might be one. But what is quite interesting in MET is we need to refine and maybe find a group which is slightly broader than the MET amplification, because we have better blockade of MET. If you really need to block MET because the driver of resistance is MET amplification, then, of course, with the side effect, notably edema of blocking MET, we have stronger MET inhibitors. So I think the biomarker is still not completed, right? We still need to look at what to do when and in which order. But today, frontline, most of the time, the only biomarker we have is a mutation, right? So that's where the life is still maybe the artificial intelligence will help us defining a bit better specific subgroups, but I think we're still not there, right? So I just wanted to discuss with you, David, what you think in the future, because there are some phase 2 and 3 trials trying to further improve what we do. So, of course, the basis of everything looks like to be a third generation EGFR TKI. And honestly, being osimertinib, lazertinib, almonertinib, there might be some little differences. They are not the same compounds, but still that is a skeleton, and then you pile up some things. So there's one phase 2 trying to pile up savolitinib in the patient who have de novo MET amplification or overexpression, which is a very wide group, knowing that amplification is not correlated with overexpression. So you might be a bit looking at banana and apples, and it's a design a bit difficult. But the other one, almonertinib and chemo, or osimertinib and dato-DXd, makes sense to replace the platinum doublet you described by another compound. Still, datopotamab deruxtecan is not easy to give. It has more side effects to me than platinum doublet, and we will probably see arriving here other MET inhibitors like the Teliso V, Teliso A, also in combination with osimertinib. So there will be other probably ADCs, but ADCs are not platinum pemetrexed. They are a bit more difficult to give. What's your perception of these trials ongoing, and will they really challenge the FLAURA2 you have published?
I would say I'm not sure they might challenge the osimertinib and platinum-based chemotherapy. Just keep in mind that all the control arm is osimertinib monotherapy, and so they might do better, but nowadays standard of care is OC plus platinum-based chemotherapy. I'm completely agree, so I'm still worried because the ADC, it's a good option. We have seen the data that ODXD, the SAC-TMT, which might do better than platinum-based chemotherapy in second line. Combination with osimertinib might be challenging, particularly in terms of ILD and the other side effect. You always have this stomatitis. You always have this hematological toxicity. So the duration of exposure to the ADC, it's still an issue. So I'm not so confident about the fact they might beat finally OC plus platinum-based chemotherapy, which makes a lot of sense, particularly on the brain mets and so on, which is important in this population, and 40% of patients with brain mets at baseline. So that's why it could be another option. Is it an option that will do better than OC plus platinum-based chemotherapy? I would say no. So that's why probably we will need to reinvent and waiting the new generation of ADC, probably the B-specific ADC, probably some ADC that block also the VEGF, like ivonescimab, that make a lot of interest to block the angiogenesis pathway. But I would say something much more advanced that completely, if you want to beat now, we want to beat OC plus platinum-based chemotherapy in terms of PFS and OS. So probably the step should be higher, and we will have some equivalent, and probably it will be challenging nowadays to demonstrate that we will change the standard of care in first line with this ongoing phase 3 trial, to my point of view.
Thanks so much. So I think we need still to follow up Mariposa and FLAURA2 data long term, because it's always important to see how much these benefits stay valid over time, maybe across subgroups. But I guess we have at least new options for our patients. We have too many choices, which is a good problem to have. So thank you so much for the discussion we could have. Our takeaways is moving the field of an important disease in Europe, but even more in Asia. And I think we will learn from each other in the future. And I'm looking forward to continue this discussion once we will have long-term results from both trials and maybe new treatment options. Thanks so much. And see
Thank you so much, Solange.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/YJT860.